Currently, Mr. Kyberts serves as a project manager for Taking Texas Tobacco Free, an academic community partnership to implement evidence-based, multi-component tobacco-free workplace programs at community behavioral health and substance use treatment centers. Through this project, Mr. Kyberts has trained over 8,500 clinical providers on treating nicotine dependence and providing technical assistance to 45 agencies to implement comprehensive tobacco-free workplace programs. Maggie Britton is an assistant professor in the Department of Health Disparities Research at the University of Texas MD Anderson Cancer Center. Originally from Michigan, she received her bachelor's in psychology from Oakland University before moving to Texas to complete her PhD in the University of Houston in social and health psychology. Her research interests center around reducing disparities in tobacco use and cessation among minoritized and marginalized groups. She has been working with the Taking Texas Tobacco-Free team to further this mission since 2021. In addition to research, she is active in her department's training efforts, helping to build the infrastructure to support trainees interested in cancer prevention and disparities. So Maggie and Bryce, thank you again for joining us, and I'm going to turn it over to both of you.
Thank you so much, Gina. Let me get my presentation shared. All right, just to confirm again, y'all can see that okay?
Yes, thank you.
Okay. All right, well, good morning, everyone. Thank you again, Gina, for the introductions, and thank you to the Virginia Department of Health Regional Coordinators that invited Bryce and I here. And thanks, of course, to y'all who are in attendance and for putting your information in the chat so that we have a sense of who is here. Glad to see that y'all are on the same page as us, that addressing tobacco dependence in behavioral health settings is very important. And hopefully today we can give you some more tools for your tool belt to help you feel more confident in addressing tobacco use. So here is our outline for today. So first, I'll talk with you a little bit about Taking Texas Tobacco Free. What's our model? What are our outcomes and the impact? And then I'll turn it over to Bryce to talk about the interplay between tobacco use and behavioral health, why it's important to address tobacco use in behavioral health settings and the barriers to doing so. Then I'll talk about brief interventions for tobacco use that can be completed with both minimal effort and also minimal training. And Bryce will talk to y'all about how you can get started with making tobacco use a priority at your workplace. And then I'll finish off with just some professional resources for your continued tobacco education. All right, so starting with Taking Texas Tobacco Free and what is our program? So this is a cancer prevention program, and the mission is to promote wellness among Texans by partnering with healthcare organizations to build their capacity for system-wide and sustainable initiatives that can reduce tobacco use and secondhand smoke exposure for their employees, for their patients, and for visitors to their property. Our program includes various components that I'll review on the next slide, but essentially we work with our partners on policy development and clinical workflow changes to guide a tobacco-free environment and a tobacco screening and treatment or referral program. All right, so like I said, on the left-hand side here, we have our program's core components, which boil down to what our partners implement. So they implement a tobacco-free workplace policy. They implement tobacco use screening services, as well as treatment or referral to treatment. And then we have employee education, where Bryce works closely with our centers using a train the trainer model to ensure that the workforce can remain competent in tobacco knowledge even after our program implementation is complete. We have a number of strategies in the middle column that we work with centers on in order to realize these components. I won't go into each of them in detail, but they largely include preparation and planning together between us and the partner organization to ensure that we have organizational support and to appoint a program champion. We work on capacity building and resource provision. So this includes training that we provide to all staff. We do provide starter kits of nicotine replacement therapy, as well as patient education, provider support tools. We help with infrastructure enhancement, which might include things like permanent tobacco-free workplace signage. And we also work on quality assurance and ensuring the regular review of the program and making adaptations where needed to ensure that the program can fit in the center that we're working with. So together, all of these strategies address some of the barriers in the settings that we work in. This includes things like limited capacity and certain attitudes and perceptions around tobacco use. I won't go into these in detail. Bryce will be talking about some of the specific barriers to addressing tobacco use in behavioral health care settings later on. So tobacco-free workplace programs like ours are evidence-based, so they have been shown to increase clinician self-efficacy to deliver tobacco interventions, as well as increasing the actual delivery of the interventions. They increase client and employee quit attempts and their success in those quit attempts, and they also reduce secondhand smoke exposure. To give you a brief overview of our impact over the past 10 years, we've educated over 16,000 professionals about tobacco use across 315 trainings. We've disseminated over 900,000 pieces of health promotion materials, and we've worked with 349 agencies. And these include mental health and substance use treatment facilities. Specifically within substance use treatment centers, we've also worked with a number of opioid treatment programs. And over the last few years, we've expanded our program to target rural and medically underserved areas of Texas. And so we've also included some federally qualified health centers and rural health clinics in the mix, recognizing that folks in rural areas are often seen for their behavioral health needs in these more primary care settings. And so just on the maps here is our reach to date, specifically in substance use treatment settings on the left, and then mental health treatment facilities on the right, with the counties colored in being the counties that have been served by our partner agencies. All right, I will turn it over to Bryce to talk about all of our topics around tobacco use and behavioral health.
Wonderful. Thank you, Maggie. And so if you'll move it on to the next slide. And so the main reason why we are addressing tobacco use is as we all on this call likely know, is that smoking is a leading preventable cause of death and disability in the United States, in Texas and Virginia, wherever we go. It's what's harming and killing the most people in our country. And our specific focus within people receiving behavioral health or substance use care are a specifically vulnerable population. As you can see, that smoking tobacco use cuts lifespan of individuals who have mental illness by 5 to 15 years. So we see folks dying at age 50, 52, 55, rather than living a little bit longer to 70, 75, or 80. One that's common theme here at our facility is the people that we're treating there, they're not dying from their mental illness, they're dying from their tobacco use. And that treating their tobacco use is one of the most effective healthcare intervention that we can do to help them live a healthier life and prolong their life as well. And then when we also throw in smokeless tobacco and secondhand smoke exposure, we're adding about another 80,000 deaths annually. So we're easily over that 500,000 deaths each and every year from smoking a combustible cigarette or being exposed to secondhand smoke or use of smokeless tobacco. Want to move to the next one there, Maggie? And so when we're talking about the health consequences, the very first bullet here really outlines or illustrates how much tobacco use is truly impacting people who are living with a mental illness or have a substance use diagnosis. that these folks, they make up about 25% of the population, which is a very small percentage of the population, but they're consuming over 40% of all cigarettes sold in the United States. I think the statistic is 44% of all cigarettes. So they're really using a lot of cigarettes, which translates to that they're incurring a lot of the health consequences, a disproportionate number of health consequences. And not only is it impacting their health, and we'll talk about their mental health in a little bit, but it's also impacting them financially as well. So it's very important for us to be having these conversations with folks. And as we can see here from the next two bullets, that very, very high use rates among people with specific mental illnesses, people who are living with schizophrenia, anywhere from 70 to 85% of folks are smoking cigarettes. People with bipolar disorder, between 50 and 70%. And then when we look at substance use, this is extremely high use rates, from 70 to 87%. With some of our opioid treatment centers that we've partnered with, we're almost seeing a one-to-one relationship, anywhere from about 90 to 95% of the people within some of those opioid treatment centers report smoking cigarettes. So as you can see, these are really the two populations that we need to be focusing on and continue to offer treatment services to. All right, next slide, Maggie. There we go. So why do we address tobacco use in behavioral health settings? And I think that first screen kind of showed it, or the previous slide really kind of emphasized that. But one thing that we do know is that there's a lot of there's a lot of misconceptions and beliefs and misinformation out there. And one, that people with substance use disorder or a behavioral health condition, that they don't want to quit. And we know that that's not true, that they are motivated to quit. Anywhere from about 50 to 70% of people have tried to make a quit attempt in the past year. But what we're finding is that they're trying it by themselves, they're going it alone, and they're trying different things that are not evidence-based techniques. So one thing we see a lot, people switch from cigarettes to electronic cigarettes, or they switch from a combustible cigarette to spit tobacco, or they're just try to go cold turkey. All of those things, they're not very successful. They're unable to quit smoking. And not only do maybe some of the people that we're serving believe that they're unable to quit, maybe clinicians also believe that no matter what we do, whatever service we provide, they're incapable of quitting smoking, which is absolutely not true. And we'll touch on some of those evidence-based treatments to help people and give people a better chance of being successful, rather than just kind of leaving them out there on their own and having them try some things that they think might work. And then it's going to jeopardize their recovery if they quit smoking. And then when we talk about recovery, it might destabilize their mental health recovery, or it's going to be too much for them and they're going to relapse and start using alcohol or drugs. So that's when we kind of talk about jeopardizing recovery. That's what we hear, and that's what we talk about. But we do know that when people do quit smoking, we lower the risk of their substance use relapse and decrease negative mental health symptoms, which we'll talk about in a little bit more detail in a couple more slides. And here we go. And this slide is very personal to myself. Early in my career, I have an undergraduate degree in alcohol and drug abuse studies. I was a drug and alcohol counselor for about 3 years at an inpatient and outpatient treatment program. And all through my undergrad and during my internship and my work at the substance use center, I was trained and told not to help people quit using tobacco products. And that was going to be bad for their recovery, that get them clean, get them sober, get them stabilized. And then if they want to quit smoking, then they can quit smoking. And many, many people never, ever made it to that point of actually quitting smoking. And the way I was trained many years ago actually was wrong training. And what research is showing now is that quitting substances and quitting tobacco at the same time enhances recovery. It doesn't jeopardize it. And as you can see here, one of the studies that was put out by Dr. Francesca in 2004, what her study found was that 25% likelihood of long-term alcohol and drug abstinence. Other studies have shown that continued tobacco use is actually a very a very strong trigger for people to relapse and start to use their drugs. So not only their drugs and or alcohol of choice, so not only are we seeing that quitting at the same time enhances recovery, but by not addressing tobacco use puts them at a greater risk of relapse. So it's very important that we do put these two things together, and really classifying tobacco use and the use of nicotine as an addictive drug, which it truly is. And as you can see in some of our posters here, quitting smoking is one day at a time, utilizing some of the same language that they use in the 12-step model for alcohol and drug recovery through Alcoholics Anonymous or Narcotics Anonymous. So we're really making that connection that nicotine is a highly addictive drug, same as alcohol, same as heroin, same as methamphetamine, same as cocaine. And when we do look at mental health symptoms, and that's something that we hear time and time again, that people are too anxious, they are too stressed out, they can't quit, it's going to make their depression worse if they quit smoking. And we absolutely do not see that. And kind of one of the first studies, meta-analysis, was this Taylor study in 2014 that showed when people quit smoking, we see significant decrease in anxiety, depression, and stress. We see increases in psychological quality of life and positive effect, and that those associated improvements were greater than or equal to prescribing antidepressant medications for depressive and anxiety disorders. And so we see not just small changes, very pronounced changes when people quit smoking, and a natural elevation of their mood and their quality of life. And for that last bullet, we're not saying that by quitting smoking is kind of like the magic bullet to help them with their depression, and that we should stop prescribing medication. So please don't take that bullet as that's what we're saying. What we're saying that as they quit smoking, their mood's going to improve naturally when they quit smoking. Their medications more likely are going to work a little bit better because of how the medication is being metabolized by secondhand smokes, the impact on how the medication is metabolized. And third, more than likely, they're going to have to take a lower dose of the medication. So it's really a very win-win-win situation for the people that we're working with to help them live a healthier life and improve their long-term mental health.
Bryce,
Yes.
this is Nicole. Just want to interrupt you real quick, while you're on talking about smoking cessation and recovery. And there's a question in the Q&A, just kind of, she was asking, how much are you shifting some of the focus to look at vaping or helping people stop vaping? So has that been a question that you've received when you're working with your partners? Is it just combustible cigarettes, or are they also looking at helping people quit vaping as well?
When we do our trainings, we include vaping in our trainings, and that we want people to live a nicotine-free lifestyle. And so it doesn't matter if they're using combustible cigarettes, cigars, hookahs, smokeless tobacco, spit tobacco products, or vapes. We want people to live their life tobacco-free and nicotine-free. We talk very openly and honestly about the current research that we know about electronic cigarettes, and that more than likely they are less harmful than a combustible cigarette. But we don't really encourage people to use them. It's not an FDA approved medication. There's some evidence that they work well for folks, but not really super strong evidence for it. So we know that it's an option. We know that a lot of people are using it, and we encourage people to stop using them and to become 100% nicotine and tobacco free.
Great, thank you. Thank you for that answer. Just I guess the takeaway is to really just be totally comprehensive, and you'll probably go talk about that when you do policy as well, just to include all tobacco nicotine products.
Very
Great,
good.
thank you
Very
so
good
much.
question. Thank you. Yeah. All right, Maggie, want to advance? Okay, so now we'll talk about some of the barriers real quick of what we see actually happening in the centers to address tobacco use and to push to get some of these policies moved forward. So some barriers to intervention. This is at a clinical level of what we see, why clinicians or why centers aren't addressing tobacco use or providing interventions to the people that they're serving. Like I talked about earlier, those misconceptions and myths and misinformation about joint tobacco use and substance use and mental illness, very, very pervasive. And that's probably one of the biggest challenges that we see, this permissive culture of smoking, where smoking is really ingrained in a lot of things that the way the clinics run or centers run. I talk about my job, my work as a substance use counselor. Before I became the substance use counselor during my internship, I was a rehab tech. My job at our inpatient treatment center was to go around and take orders for the people in treatment, and then I would run down to the convenience store and purchase their cigarettes to bring them back to their center. That was how permissive that culture of smoking was at the treatment center. And then everybody smoked inside during groups in their rooms everywhere. That was how permissive it was at the treatment center that I worked at. And for some places that still lingers, and that's still there for some components of that. Many treatment providers are reluctant to address tobacco use because of they don't have this knowledge or that confidence. And we asked that in that first poll question, and where we saw, somewhat confident in your abilities. That's kind of where we're at with a lot of these centers. They don't really feel like they have the knowledge or the skills or the information to address that. And when they don't have that confidence in their abilities, they're less likely to deliver these interventions and have these conversations. It's someone else's job to take care of, right? And they kind of kick it down the curb. And we see this at larger mental health centers where maybe it's a crisis and they're not going to bring it up, or it might not be the right time to bring it up, which would be appropriate, but then it never gets brought up. It doesn't be brought up maybe with their personal counselor or with a rehab tech. So it just kind of disappears and the responsibility is diffused and passed on to someone else, and then no one ends up doing it. Client reports that it helps with symptoms or that they're under a lot of stress. Yes, absolutely. But we have a lot of skills and techniques on how we can help people deal with some of those symptoms and that stress without using a harmful and deadly addictive substance. Now we don't want to police tobacco use, and there's some ways that we can address tobacco use in a very trauma-informed care manner. We actually have some resources on our Taking Texas Tobacco Free website, a couple of videos on how to do that. And so there are some ways that we can have these conversations in very client-centered and trauma-informed manners, that we're not policing people and telling them what they could or what they should or shouldn't do. So those are some of the barriers that we see and that we strive to kind of overcome when we work with centers. So some barriers to becoming tobacco free, and this is looking at the entire facility with becoming 100% tobacco free, and that center administration have concerns about census, and that's something that we run into a lot, especially with the substance use treatment programs, that if we become tobacco free, they're going to go next door. They're going to go to another treatment center in the city, or they're going to go 10 miles up the road. And we don't see that happen at all with the centers that we work with. No center, and we've partnered with almost, I think, 26 substance use treatment centers and probably 28 mental health centers. And none of them have reported a decrease in client census, or employees haven't resigned and left their jobs because of the facility becoming tobacco free. Staff may not support the policy, or they threaten to quit their job. Policies are hard to enforce, and nobody's going to abide by the policy. And policies can be enforced with adequate training and expectations for all staff to address those violations. And this sounds kind of silly, but signage, just having signage up so people know what the expectation is, that goes a long way and people do respect that for the most part. No center will always have 100% compliance, but it's really kind of amazing how much of a culture transformation takes once a center becomes 100% tobacco free. Infringement on personal rights and taking away their personal freedoms. Tobacco-free policies do not violate personal or client rights. They can continue to use their tobacco products. They just can't use it on the center's property. And that goes for both employees and for people who are coming in for services. So those are some of our talking points and some of our experiences of helping center become 100% tobacco free.
All right,
All right.
thank you,
Hey.
Bryce. All right, I'm going to move on to some brief interventions for tobacco use. So the public health guidelines indicate that we should use the 5 A's at every encounter that we have with clients and patients. And so that includes asking clients about their tobacco use, advising them to make a quit attempt. And so something as simple as letting them know that quitting tobacco is one of the best things, most important things that they can do to live a healthier life. Research shows that this brief advice from a healthcare provider does help to motivate people to think about their tobacco use and to make a quit attempt. And then after the advice, assess if they're interested in quitting. And so if they are, we have to have a way to assist their quit attempt through things like counseling and medication, in-house, or a referral. And today we'll talk specifically about how the Virginia Quit Line is a great way to assist your patients or your clients' quit attempts by connecting them with tobacco dependence care that's free, accessible, and evidence-based. And then the last 5A is arrange. So arranging a follow-up to talk with them about their tobacco use again. So I'm going to talk a little bit about the evidence base behind quit lines before I talk specifically about the Virginia quit line. So quit lines are an evidence-based, cost-effective tool in our arsenal against tobacco use. So quit lines remove barriers that are often associated with healthcare, like cost and transportation, making them a really equitable option for all patients and clients, irrespective of their health insurance status or their coverage. And so some of the evidence behind this compared to people who use minimal counseling, no counseling, or who do self-help, so they're just quitting on their own. The use of quit lines increases those quit rates, or the people who have successfully quit, by 60%. And quit lines are even more effective than that when they combine their counseling services with the FDA-approved medications like nicotine replacement therapy that the Virginia Quit Line does offer. And again, we'll talk about that in a minute. Quit lines are an excellent way to extend the care that you can provide to your clients or patients. And specifically, they allow you to address your clients' tobacco use with evidence-based care without forcing you to become the expert in this area or to spend extensive time during a patient or client visit on their tobacco use. Ideally, though, the quit line should be offered with some level of complementary support, like we said, arranging a follow-up to discuss how are things going with the quit line, and providing additional supports there as needed. So over time, the way in which we've gotten patients connected to the quit line has evolved from what I'll talk about as a refer approach to a connect approach. So in the earliest days of quit lines, providers would give patients a card with the number to the quit line and get them to call. So the onus is on the patient to make the call to get the services. This is what we call the refer method. And now there are lots of ways for us to directly connect our patients to the quit lines, including things like fax referrals, e-referrals, online systems, phone apps. And through these methods, the patient can be proactively contacted by the quit line for services. So most recently, the e-referral method or referrals that are made through an electronic health or medical record have been recognized as sort of the gold standard. So, oh, excuse me. So referrals that are made through a health record can increase the number of referrals that are being made 3 to 6-fold versus when people are using just a fax referral method. And the e-referral method allows you to remain informed about patient care and treatment outcomes, potentially through EHR messaging. And the fact that it's in like a patient record can serve as a reminder to follow up. So that's kind of why the e-referral is the gold standard. But any of these methods in which we are connecting the patient to the quit line versus asking the patient to do the work to receive the services is a better option. And I'll talk about the evidence behind that on the next slide. But I also wanted to mention that there has been some work done on providers making warm handoffs. A lot of this has been done in sort of a hospital inpatient setting. So a provider or staff calls the quit line directly from the bedside, hands the phone to the patients for immediate enrollment in counseling. And this was, of course, extremely effective in getting people to engage with the quit line. In a study, 99% of the people who were provided with a warm handoff enrolled in services versus only about 60% of those who received a fax referral. So in case that is applicable to anyone here, I did want to mention the research behind warm handoffs. Okay, and I said that I would spend just a minute showing the evidence base behind this Ask, Advise, Connect method in Texas. So from 2010 to 2012, 2 studies were conducted in Houston to look at the effectiveness of an Ask, Advise, Refer approach versus an Ask, Advise, Connect. So in Ask, Advise, Refer, patients are provided with the number to the quit line and asked to call. In Ask, Advise, Connect, patients are proactively contacted by the quit line after an e-referral is made by the provider. One of the studies was conducted with family medicine clinics and the other with safety net clinics. And what they found was that in both settings, the enrollment rate for an Ask, Advise, Refer was very low. So less than 1% of the smokers enrolled in the quit line. On the other hand, the enrollment rate for the Ask, Advise, Connect method was 7.8% in the study with family practice clinics and 14.7% with safety net clinics. So a really, really large increase in the number of patients that were getting connected to services. And this really just highlights the impact that making that connection will have on getting your patients to uptake the quit line services. Okay, so what does the Virginia Quit Line offer and to who? So the Virginia Quit Line provides services to individuals who are at least 13 years old and who use nicotine or tobacco-based products. Tobacco users can be referred if they are thinking about quitting or they are ready to quit in the next 30 days or ready to quit right now. They can also call if they've already quit and need help. Or relapse prevention support to stay quit. And I wanted to mention that because I think that that's a really cool distinction with the Virginia Quit Line. Not all quit lines will offer support to patients who have already quit or who are just thinking about quitting. For instance, the Texas Quit Line doesn't offer support unless a patient is ready to quit within the next 30 days. And so that's a really great resource for patients at kind of any phase of their readiness to quit. The Virginia Quit Line offers a 5-call program and 2 weeks of nicotine replacement therapy where they have the nicotine patch and the nicotine gum as offerings. And I'll say that they address the needs of their priority populations through various special service programs that are slightly different than that offering of 5-call and 2 weeks of NRT. And so this would include things like extra nicotine replacement therapy or extra calls or sessions for groups that are uninsured or 18 to 20, folks who are pregnant or who are postpartum, individuals with behavioral health needs, and then youth populations under 18 receive access to an online dashboard and an option to chat with a coach, but they don't receive nicotine replacement therapy since NRT is not FDA approved for folks who are under 18. So those are just some of the cool offerings, and we'll talk a little bit more about how you can find out more about getting your patients connected in the next session. So we talked about providing, how providing a direct connection to patients is really the best method. I did though want to highlight a free resource that is more in line with the refer method. So the Smoking Cessation Leadership Center at UCSF does provide 250 free quit cards. It's this link at the bottom here that's an order form, the one with Qualtrics. And this number on the card, the 1-800-QUIT-NOW, directs callers to the national quit line number, and then callers would be connected to their state quit line. When I ordered these for our program a couple years ago, they're kind of slightly bigger than a business card, but they're like a nice material card that folks can keep in their wallet. And the reason I mention this, even though it's not a connect method, if you have patients who are not willing to be connected, you can say, okay, no problem, we can talk about it later, arrange a follow-up with them. And in the meantime, let them know that if they want to talk about quitting, here's some information. It's a non-pushy, easy way to make sure that clients have the information they need, because we know that motivation to quit fluctuates. And so if they're not ready at the appointment, that's okay. Here's a resource in case they are ready before you see them again. Okay, and speaking of clients or patients who are not ready to quit, I did want to mention something else to use that complements kind of the 5 A's for patients who are interested in quitting. For folks who are not interested in quitting, we have the 5 R's brief intervention, which is relevance, so encouraging the patient to think about why quitting is personally relevant to them. Risks, so asking a patient to identify potential negative consequences of tobacco use. Rewards, asking them to identify potential benefits of stopping using tobacco. Roadblocks, what are the barriers to them quitting? And then repetition. So this is a motivational intervention that can be repeated every time that you have someone who is unmotivated. So every time you have an interaction with them. And for tobacco users who have failed in previous quit attempts, we should remind them that this is normal, that most people make repeated quit attempts before they are actually successful at quitting. And I have the images on here. For the 5 A's and the 5 R's, I did want to mention that these are badge cards, typically is how we print them, and they are available on our website to print. So you just have to go to our provider materials page linked here. And then in addition to having like the badge cards that we can use in a health setting, there are also complimentary like 8.5 by 11 pieces of paper that have some open lines where they can be used for clinicians to write in notes about the patient encounter, or they can be used with patients to have them kind of fill it out, be thinking about these things. So I did want to mention that those are available on our provider materials site. And I will turn it over to Bryce on how to get started at your workplace.
All right, all right. So I think the main takeaway here is how to get started at your workplace is talking with your regional coordinator, getting in touch with your regional coordinator, connecting with them. Before I move to the next slide there, Maggie, and either emailing them, calling them, setting up a video chat call with them to find out how can you move forward with these various interventions. And then interested in making a referral. Want to go to the next slide there. Maggie kind of talked about that. Here's the link for the electronic referral service within Virginia, so that you can just make that really quickly from that website. And then the next step is kind of how do you start this conversation about becoming tobacco free or addressing tobacco use at your center. And we always encourage folks, regional coordinators, folks that work at a center, to start at the top, and having that conversation with the CEO or the executive director, the executive management team, whoever that might be, and getting them connected and getting their ideas and their resistance or their support for the program, because that's ultimately where it's going to roll down from. So we might as well start at the top. Identify where they currently stand with, maybe they've tried something in the past and it didn't stick. So those are all really useful conversations to find out, what did they try, what didn't work, and why didn't it work, so that we can maybe fix that. So next time they do try it, they'll be successful, and we don't have that same problem happen. Outline how you can help them, what resources that you can provide to the center. Share contact information with nearby centers or organizations that you know that have become tobacco free or are already doing this work, and how do they do that, and what are their outcomes of those centers. And you can use some of the examples from our website of, this is what folks are doing in Texas, and these are the outcomes that they're seeing in Texas. Although Texas, Virginia, not one-to-one, but at least it's an example. Seek a solid commitment from the center and appointing a designated champion to take the lead on that initiative and be that contact. So some talking points for the leadership on the next slide there. One thing that I encourage centers to do is review a mission statement. A lot of times mission statements say, we want to provide the best healthcare, the best substance use recovery, the best mental health recovery, whatever that might be. How can you say that you were going to be providing that when you're not addressing a deadly and addictive use of tobacco products? So really kind of holding people's feet to the fire on their mission statement. And if they're excluding tobacco use in there, they're not truly living up to that mission statement. Tobacco-free policies may align with other healthcare providers in the community. And so that could be that you're lagging behind. A, B, and C centers are already doing this, and they're having really good outcomes. We need to get caught up and do what they're doing as well. Kind of that peer pressure, peer influence thing. Tobacco use is an addiction. Treating all addiction together is evidence-based, like we talked about. And like we talked about earlier, we don't see census drops when facilities become tobacco free. In fact, people seek out these services. They want to quit, like we talked about earlier. And we know that it is an evidence-based approach. So the next slide, Maggie, there. When you do talk with a center or within your own center, know what city, region, area that they do serve. Be aware of the demographic factors within that center. How many people do they serve individually, but then also their annual visits? How many employees? Are they urban or rural? Things like that. English and Spanish speakers. One thing that's really important, and I'll touch on, is the electronic health record system. What are the capabilities? Is a tobacco use assessment embedded? And for mental health centers, this is really important because of the transient nature of our clients. Sometimes they fall in and out of services, and it's kind of hard to track them and follow them if we're using paper charts, but it's much, much easier if we have an electronic chart. So if someone does drop out of service for 2 years, we can circle back and find out, what did we do with that person 2 years ago, and to continue to track that person. Understanding their governing bodies and their governing procedures, how are policies and procedures approved and made and implemented, and then asking a lot of questions, probably taking people out for lunch, and just getting to know them and understand some of the challenges that they're facing at their center. And then the final slide is identifying a champion. And we think that having at least 1 or 2 folks really to lead these initiatives is critical. And having a clinical champion who understands the clinical aspect of the organization, and an administrative champion, a person to kind of take care of the behind the scenes things like that, really help move things forward and make things happen at that center. And then just having that regular communication with those champions. Don't let it fall off their radar, keep moving forward. And then, if the center doesn't have that appropriate level of support, you might have to just let them walk away or back away from assisting them until a more appropriate time to work with them comes up.
All right, thank you, Nicole, for the time check. I promise I will make this very brief, especially since y'all will be getting the slides, but I'm just gonna breeze through some professional resources that are available for continued tobacco education. So of course, there are listservs that put out different communications, the latest research on tobacco, the latest treatments. They also provide notices about trainings that are coming up. And so you can subscribe to all of the listservs and get all that information, but I do also want to make you aware that our program actually puts together a bi-monthly, so it comes out on the 1st and the 15th of each month, a list of trainings. We try to include things with continuing education credits. Sometimes they don't have them, but to the extent that they do, we always include those first, because we know that for a lot of clinicians and providers, continuing education opportunities are important, and these are always free continuing education opportunities. If you are interested in getting signed up for this, you can email Bryce or I, but you can also email takingtexastobacco-free@gmail.com. Something as simple as add me to the trainings list, add me to the CEU list. It will get you put on the list, and one of our coordinators, one of our data coordinators will reply back and confirm that you're now on the list. At MD Anderson, we have something called Project Teach. This is an echo clinic that happens twice a month on Tuesdays. They do both didactics and case presentations. So if you're struggling with something that you're working out in the clinical setting, you could do a case presentation and really have that that peer support and advice about what to do. And they do offer free CEUs and CMEs. How to join that is just emailing NTobacco, and then this link has more information about that, as well as the QR code will take you directly to that link. We have a number of free continuing education, or I'm sorry, we have one free continuing education module on our website. This is through Integral Care, and they have 0.75 hours of continuing education for different mental health professionals. But we do have a number of other training materials that are not, they don't have free CEUs linked to them, but they target various different population demographics, such as women, Black adults, the LGBTQ+ communities. And then the last thing I'll mention is that we do have a newsletter that comes out every quarter. Some of the information may not be as relevant to a non-Texas audience, but we do give updates on what's going on with our program. And then the real reason that I put this here is because we highlight all of our new provider resources. So whenever we create education materials, videos, etc., for various populations, we do highlight those in this. And so you can absolutely visit our website. There's a little thing that pops up that says subscribe me, or you can scan the QR code here, go to this web page. So, and that is it. Thank you all so much. And I will turn it back over to the Virginia folks.
Hi, yes, thank you, Maggie and Bryce, so much for that great information. I think these resources and the information that you shared in your PowerPoint is really helpful. And I just have one question, if you could answer it quickly. I'm going to kind of combine three questions that we've had today. People kind of asked, about centers who have had issues with going tobacco free. For example, if clientele, they're afraid that if they go tobacco free, that they won't have the clients. And so I kind of want to combine that question. And I mean clients as in, people want to smoke. So will that in turn, and I know Bryce talked about, there's no census drop, there's no drop of clients from going tobacco free. And in the Q&A, we had a question about, in Texas, have behavioral health centers that were early adopters of a tobacco-free policy played a role in educating behavioral health centers without a tobacco-free policy? So if you want to touch on both really quickly, if, early adopters have kind of helped kind of serve as examples to other behavioral health centers. So however you want to answer that, feel free to either of you.
Yeah, I would say our early adopters, and we absolutely had very early adopters. And I wouldn't say that they've necessarily helped, but they have been a wonderful resource for us to say, so-and-so center did it. You could reach out to them and talk to them about their experience. And But they certainly haven't been a hindrance, say, no, this isn't something that you should do, or come out and say that this has been a bad thing for us. So, but I think it's been good. And the first part of the question is, I think that the tobacco-free policy work, it just kind of starts transforming that culture where people, Integral Care, where I work, which is a community behavioral health center that serves Austin, we became tobacco-free 10 years ago, almost 11 years ago. And smoking is just not an issue, at our facility. And then it didn't take 10 years for that to happen. It took about 2 years for that to transform the culture and we see that from time and time again. And employees don't smoke anywhere on our facilities. We have a couple clinics and a couple kind of hot spots where people do smoke, but we put, we address it on a regular basis at some of those places. And so it's not really an issue.
Great, thank you so much. And I also wanted to say, I liked how you talked about, in some instances, sometimes you are able to back away and come back to them later. So I think it's a great point to kind of give yourself grace, and you can take a step back and come back to it as well. So I think there are so many great points. We just don't have enough time, unfortunately, but we will send the PowerPoint.
Yeah. One real quick thing is I kind of relate centers or organization becoming tobacco free along that continuum or that process of people wanting to quit smoking. People might not be ready to quit today, and maybe they take little steps moving forward and then they take some steps back. Same way with organizations, they kind of prepare and they move forward and they move back a little bit along that continuum. So it's kind of similar in some of those ways.
And that's a great point. And I appreciate you saying that, it took kind of 2 years for your organization to go tobacco free because it takes time, it's not just going to be overnight. And I think sometimes we kind of get bogged down on the barriers, but it's good to know, and have those examples also on your website that you mentioned, that we can look back on. So again, thank you so much. I want to send this over to Gina to kind of wrap everything up.
Bryce and Maggie, thank you so much. It was a wonderful presentation, so much great information. I think I was writing notes the entire time. You have so many great points that I could mention. A couple that really stand out. One is your talking points for leadership, because I think we all know that this is where we need to take our first step, is reaching out to the top so that they can appoint a champion, both clinical and administrative. I love that point too. So great advice to Virginia as we move forward. Maggie, I love the concept of that warm handoff, right? 99% successful. So, and I know Rita's on the call. She has kind of started thinking about that word connect, advise, ask, advise, connect versus refer. So I think this is great strategy for Virginia to kind of take and run with. I encourage everyone, and I know Natalie, thank you for putting all the links in the chat. Please go to their website. They have so many materials that can be very beneficial to what you're doing and what you're working through. So I definitely encourage that. Thank you so much again. I do want to invite everyone to join us March 19th for our next Tobacco-Free Tuesday. We will have an update and a wrap up from the General Assembly. If you're involved, and I know many of you on the call are, it's been a busy few weeks. Several tobacco bills are in there, and we will have a wrap up at our March Tobacco-Free Tuesday. So join us for that. Enjoy the rest of your February. Stay warm. I think spring may be early this year. No snow, although I'm still hoping for one more. I'm not sure I'm going to get it. So just enjoy the rest of your February, and I hope to see you all in March. Thanks a lot. Bye.
Thank you so much.
Thank you, Maggie and Bryce.